Well, thanks very much, Art. I would like to just here at the beginning kind of set the table for sort of how these problems have persisted and how the pandemic kind of put a real point on the issue that was already existing, frankly, as you point out, Art. It was an already existing problem, but that has really been accentuated by the pandemic. Now, at the beginning in the COVID-19 pandemic, I was there at HHS at that time, and we knew very early in the pandemic that the restrictions, the lockdowns that were taken to mitigate the spread of the disease, its morbidity and mortality, really at the time was an unknown viral agent. It was going to take a toll on the mental health of Americans. That was highlighted for us, not least by Dr. McCants Katz that you're going to hear from later. And of course, this toll has been taken broadly across the entire country, indeed the world, but the group that has suffered in many ways the most are children. So the fallout has really hit them hardest in many ways. Now, prior to the pandemic, as I mentioned, we knew there were already major gaps in mental health and in substance abuse resources for children. Up to 22% of school-age children had been diagnosed with a mental health condition prior to COVID-19, and up to 80% of them had unmet mental health needs. So that was already kind of a pre-existing issue before the pandemic hit. Now, we had already been working, having recognized this, we'd already been working hard to put in place new resources to make it possible for adolescents, just like adults, to get mental health care. Now, prior to the pandemic, these plans were already kind of in train. But when you look at what happened in the pandemic, there were some very and I think in many ways very good responses that we were able to get out there in the middle of the pandemic that might have long-lasting good effects on our ability to deal with mental health and substance use issues for children and adolescents. So one of the main things was telehealth technologies. Now, prior to the pandemic, there was very little use of telehealth interventions in behavioral health outside of LTI, right? I mean, there was that much access to it outside of this, and it was very limited in many ways, especially on the reimbursement of it and the spread of it. Particularly, it was constrained both technologically and in terms of the ability to pay for it. Now, we worked early on in the pandemic. You saw it in March of 2020. So you're saying 2 months or less after we even learned about the virus, we put in place new rules that allowed people to use things like Zoom and other platforms to be able to access medical care and get reimbursed for it. So Medicare and Medicaid could pay for it, and the commercial payers followed suit, as they often do. That just really, in medical care generally, it was a huge uplift in the use of telehealth technologies, really by a factor of 1,000%, hundreds of times, 100x from the first week of March to the first week of April in terms of what we had seen. So it was an explosion of use of telehealth across a broad variety of medical areas. But one of the most significant was mental health and substance use. Maybe a point of interest, we actually prepared for this because we were preparing a big rural health rollout later on in 2020 prior to the pandemic. And so we were already planning from a policy point of view to look at telehealth and sort of increase its access. But obviously in the middle of the pandemic, we were able to move on that very quickly. 3 different agencies that had to do different regulations, which is not a small feat inside the government to be able to get 3 different agencies to cooperate at the same time on a particular area, but it did happen. Now, implementing telehealth, it is not like flipping a switch. We had to move pretty quickly, but to get it there, you have to fund things like training providers to be able to use it, be able to assure privacy so that people can have some level of security and comfort in accessing it, to make sure it's compliant with people's understanding about how they're going to be compliant with HIPAA, and addressing billing issues, so that would be more sustainable over the long term financially for the providers who are providing access to these services. Now, because as we all know, we remember it very well, there was very limited ability to do face-to-face visits. Most non-emergency care, however construed, was constrained in there. So people weren't getting regular access to healthcare. Now, and telehealth is and will continue to be important in areas that it always was, like rural areas, like where I grew up. And one thing that I think is going to be important to think about as we go forward is the fact that it seems to be, we saw a huge uptick and then it went down, but it never returned. The use of it never returned to the low level it had been in before. It has become, I believe, a permanent part of American medicine. It is now at a much higher level and much greater expectations on the part of both providers, healthcare providers like doctors, as well as patients, that there's going to be far more access to telehealth and telemedicine in the future. Now, what does that mean? We're going to have to work, frankly, to make it permanent. Those changes that were made in the pandemic were temporary in many cases. So everybody who's interested in this area is going to have to maintain focus as we exit the emergency, as we exit the pandemic. And I mean, not just from a real world point of view, but also from a legal and reimbursement point of view, from a bureaucratic point of view. We're going to exit it. At some point, those rules have to be in place to enable the good parts of the response, like telehealth and telemedicine, to continue on and continue helping the way that they have been. Now, one thing that we had to realize, obviously, was that school is the focal point of life for most children, and to a significant extent, their families as well. So not just the children going to school, but those of us with school-age children, school is definitely a focal point of the families. So we assisted schools in developing sort of their on-site based mental health services to be covered by Medicaid funding. So there was an ability to kind of do that they could have face-to-face visits in school and utilize telehealth services delivered in their school settings as well. So that is the ability to kind of assist that, facilitate that is going to be important. And as we move forward and as we transition, God willing, on the permanent downside from this pandemic, we really need to make sure that particularly the children, adolescents, young people generally, that we've laid the groundwork and the capacity to be able to address their needs in the broadest way possible. And that means we have to be able to provide these resources, not just in person, but also remotely, using the technologies that have expanded so dramatically over the last couple of years. And with that sort of table setting, I'll turn it back to you, Art.
Oh, thank you, Eric. And I have one quick question on that. Outside of, I know all the work that's going on in the background to really update some of these policies that were temporary to make them permanent, because they do make sense. And we were running some data from some of the groups that went from zero use of telehealth to 100% of telehealth. Then post-COVID, it fell back to where 20% of the people went back to the urgent cares, but 80% held on to the telehealth. And this was primarily in some of the Native American tribes, Nebraska, for example. Have you seen similar? Because when it looks at our graph, it goes up and then it just peaks down and goes level. So
it's wound its way into everything. And I mean, some of the surprising areas that frankly never expected things like teledentistry to appear, right? It permeated into every area. Podiatry, dentistry, like everywhere. I mean, obviously you're not going to be doing surgery remotely yet, but the point is that so much, I think people were very creative when they had to be to understand how to put it into everything. And it has never come down to where it was before. And so it has become, as I said, I think it's a permanent part, and it's at a much higher level than it ever was before. It was an unusual, peculiar corner of medicine in the past, except for areas very remote like Alaska, where it had been an accepted part of medical practice for decades. Outside of that, and very unusual circumstances and very remote and rural areas, it really wasn't part of anybody's daily life to deal with, and it wasn't thought to be. So, as I said, I think you're right. I think it is. I think your experience of that is the same. That it has leveled off from that really tremendous peak, because so much of medicine has to be in person. It has to be person to person, has to be in person touch, using touch, using things and the people to deliver the services. So it's got a lot of it moved back into physical one-on-one or however many encounters, but it's not, a lot of it is now being able to be done. And I mean, it was a very creative response in unusual circumstances, but I think it taught everybody that there's a lot more we can do in this area, and it has increased access to a lot of things that I think people didn't think could be done this way before, and allowed people to get care that they could not get before in any practical way. You could always tell people, yeah, you can come in to the clinic, you can come into the hospital, but they just weren't doing it from a practical point of view. And if you can change the dynamic there, it's going to be better for everybody.
And Eric, I'm sorry, one more question, because you got my mind thinking, but how important are wearables and other things to help doctors not have that physical touch for pulse ox, blood pressure, EKG?
There's been a lot of interesting programs that have been run on that area. Again, Alaska has been doing this for a while. So I'll leave one of our states off to one side because they've been doing this for a while. But yeah, all of those devices that go around that can do monitoring, and the things that are going to be downstream from wider use of them on a lot of areas dealing with even chronic disease that can help alleviate problems. Digital scales, pulse ox, remote blood pressure monitoring, lots of information that can be brought into the hands of the clinicians for them to be able to diagnose and keep aware of what's going on with their patients, to be kept better track of it. And frankly, artificial intelligence and algorithms that help monitor those things over 24/7 periods of time that are going to allow the diagnosis of patterns and things that can hopefully give people information that they need earlier, instead of everything being kind of, oh no, here's an emergency, time to go to the hospital. So I think that's a very encouraging area. And we've got a lot of smart people in the tech sector who are working very avidly to help build out those kinds of systems and devices to even enrich what we've been able to do in the last 2 years.
So it sounds to me like telehealth gives the ability for proactive health versus reactive health.
Yes. Yeah. Get ahead of it.
I think we have time for one question. And are there restrictions on how much telehealth can be used in behavioral health services?
I'll start something anyway, and ask anyone else to go into. So there are restrictions. There were restrictions, and pretty heavy ones, on use of telehealth in pre-pandemic, that it would be used only with particular kinds of programs that were encrypted. It was used in rural areas only. So there were a lot of, and it wasn't paid for in the same way. So there have been more recent determinations, for example, that payment for telehealth would be paid the same as for telehealth, mental health services would be paid the same way as in in-person visits in a lot of settings. When starting, there has to be an in-person visit to start these things off the 6 months before they begin. And then you have to have an in-person visit at least once every 12 months. So there are still guardrails around the use of telehealth in mental health services, but there have been movements to sort of equalize the treatment across different settings to make it more neutral across sites in terms of payment. So that's been a change. But traditionally, there were fairly substantial limits on telehealth, a lot of which have been removed with the advent of the pandemic. So, as we say, silver linings in an otherwise a pretty terrible situation. And if anyone has anything to add to that.
Lemons to lemonade.
Yeah, right. That's what was done there. And in a crisis situation, when we knew we had to move quickly to remove these restrictions to allow people to get care because they otherwise were not getting it at all. And there was enough bad stuff that happened because of the delay or prevention of access to medicine because of the lockdowns. There were a lot of consequences, but some of the ones that have been most apparent have been in mental health and substance use.